Research Hospital, Turkey, for her presentation.
Thank you, Rowena. Can you see my screen?
Yes, we can see it, Doctor.
Is it working?
Yes, it is.
Fine. Hello, everyone. I will present today to you new treatment modalities for acne vulgaris. Acne vulgaris, we know, is a chronic inflammatory skin disease, and it has multifactorial pathogenesis. This disease is the 8th most prevalent disease in the world, and approximately 85% of adolescents and young adults aged 12 to 25 years occur acne vulgaris in this population. It can persist or develop during adulthood. In mechanism, we know there are excess sebum production, epithelial hyperkeratinization, Cotobacterium acnes colonization in the placebo-seous unit, and inflammation. We use in first-line treatments benzoyl peroxide, topical retinoids, and topical or oral antibiotics. And now, in the novel treatment modality, we aim the regulation of sebocyte differentiation. In third generation tetracyclines, there are tigecycline, omadacycline, eravacycline, and saracycline, but there are some adverse effects about nervous system, metabolism, psychiatric disorders, urogenital disorders, respiratory system, and others, especially abdominal pain. Spironolactone is another medicine for acne vulgaris and anti-androgen, which prevents sebum production. And it is an important alternative to antibiotics. There is no high-quality evidence of its efficacy and clinical practice. And the serum potassium levels. And we must closer monitor for patients over 45 for serum potassium levels. It can be mentioned about not associated with increased risk of cancer. And there are new options for treatment, clascoterone, saracycline, teriparatone, and novel lotion formulations of tretinoin and tazoratan. Here we can see the mechanism. Clascoterone inhibits androgens, teriparatone, tretinoin, tazoratan inhibits disordered keratinization. Clascoterone, saracycline, teriparatone, tretinoin, tazoratan inhibits inflammation, and saracycline inhibits Cotobacterium acnes. Clascoterone is a steroidal anti-androgen and anti-inflammatory cream. It has no risks of systemic adverse effects, and it can quick onset of action. Improvements we see as early as at week 2, and up improvement we can see efficacy through week 8. There are some adverse effects, especially nasopharyngitis, headache, oropharyngeal pain, and vomiting. Symptomatic adrenal suppression wasn't observed in any of the clinical trials. And we can see here a fast randomized clinical trial. There are 2 subgroups. At one group, clascoterone with number 353. At 12 week, the achievement percent was 16%, and at group 2, the achievement percent was 18% at week 12. We can use many oral antibiotics for this disease: doxycycline, minocycline, tetracycline, erythromycin, azithromycin, amoxicillin, cephalexin, trimethoprim, sulfamethoxazole, and we can use sarecycline now too. Is a narrow spectrum tetracycline. I mentioned it is a third generation tetracycline class antibiotic with anti-inflammatory properties. We can use this medicine for ages 9 years and older ages. It has low propensity to cross the blood-brain barrier. It reduces the incidence of vestibular side effects. It has some adverse effects such as nausea, nasopharyngitis, headache, vomiting, diarrhea. And it isn't recommended for use during pregnancy or breastfeeding. It can be taken with or without food. It increases patient compliance with once daily weight-based dosing and decreases inflammatory lesion count as early as at week 3. It decreases in chest and back acne by week 12. It possesses anti-inflammatory properties and potent activity against gram-positive bacteria and well tolerated with a favorable safety profile. Here we can see another clinical trial. At week 12, the achievement percent in patients approximately between 45 and 55%. There are some adverse effects, especially sunburn, urticaria, vulvovaginal mycotic infection, vulvovaginal candidiasis. It is fine. We can't see oesophageal tinnitus, vertigo, or pseudotumor cerebri. Trifarotone is a fourth generation tretinoin. Is a selective agonist activity for retinoic acid receptor gamma. It is more favorable safety when compared with first and third generation tretinoins, and tolerability was acceptable, manageable on the face and trunk. Here we can see another phase 3 clinical trial. I mentioned here in this graphic inflammatory lesions at week 12. The achievement percent was 19% in first group, and in second group the achievement percent was 24% at week 12. And about non-inflammatory lesions, in first group the achievement percent was 26%, and in second group 30% at week 12. Here we can see lotion retinoids, tretinoin and tazobactam. Structure is polymerase emulsion. These medicines has anti-inflammatory effects. Tretinoin lotion reduces number of inflammatory lesions at week 12, and the most common side effects are pain and erythema. Tazobactam lotion has greater reduction in inflammatory lesions by week 12, and there are some side effects about pain, dryness, exfoliation, and erythema. And we can use herbal ingredients in the future, and now tea tree oil is effective, especially on 45 days, using twice daily. Green tea is apoptotic, sebosuppressive, and anti-inflammatory effects on human sebocytes and has antibacterial effects. Hope is another medicine about herbal ingredients, is antioxidative, anti-inflammatory, and we can use it with a gel formulation named Hope extract. And in the future, we can use vaccination too. This vaccination is against the Christie-Atkins March-Patterson factor, which is associated with Cutibacterium acne cytotoxicity. T helper 1 and 17 shift inhibitors and antibodies against interleukin 17 and TNF-alpha might offer alternative approaches for us. And after healing, we can see, post-inflammatory hyperpigmentation. We can use for this non-surgical chemical glycolic acid pills and also iontophoresis using vitamin C, A, and E. Here we can see the mechanism of the acne vulgaris. Here there are many cytokines in mechanism and potential treatments for acne in the future. They are coming for us: topical anti-androgens, melanocortin receptor antagonists, IGF-1 inhibitors, PPAR modulators, acetylcholine inhibitors, topical retinoic and metabolism blocking agents, monoclonal antibodies, antimicrobial peptides, antioxidants, phosphodiesterase inhibitors, interleukin-1 beta inhibitors, vitamin D analogs, dapsone, systemic anti-androgens, immunotherapy, and here photodynamic therapy with 5-aminolevulinic acid gel and red light. Significantly, this medicine is superior to oral doxycycline plus adapalan gel. Some clinicians use ALA-PDT as first-line therapy in the treatment for moderate to severe inflammatory acne vulgaris. This medicine, this treatment modality is useful alternative for patients who cannot tolerate commonly used topical or systemic acne treatments. Those who don't want to take antibiotics or isotretinoin, and for women wanting to become pregnant. Blue light sources, potassium titanium phosphate lasers, pulsatile lasers, IPL sources, and red light can all be used to activate aminolevulinic acid. Bacteriophages, another new treatment modality, has antibiotic resistance. And we know antibiotic resistance is among the main causes of treatment failure in acne vulgaris. With bacteriophages, we can target both gram-positive and gram-negative bacteria, and many in vitro, in vivo models have shown that bacteriophages are effective against multidrug-resistant bacteria, and they decrease biofilm formation. This treatment modality is safe and well tolerated. There are no significant adverse events. They have alternatives to conventional antimicrobial therapy, and we have advantages such as host specificity, limited cross-resistance, ease of isolation, low cost, and a favorable safety profile. Diet is important too. Despite limitations in studies investigating diet and acne, there is evidence that diet plays a role in acne and for its treatment. There is evidence that glycemic index, dairy content, dietary fats, and probiotics may play a role in acne and its treatment. Here we can see in this picture, probiotics and omega-3 fatty acids inhibit the mechanism of acne vulgaris, but increased glycemic index, dairy products, and meat stimulate the acne mechanism. And in conclusion, low glycemic index reduces free androgens, increases IGF, BP3, and decreases IGF-1. Dairy products increase insulin and IGF-1 levels. Omega-3 fatty acids decrease IGF-1 and inhibit pro-inflammatory leukotriene B4. And with a vegan diet, we can decrease TORC1, leading to decreased signaling of pro-inflammatory nuclear factor. And also possible production with probiotics. We can with probiotics we can increase the anti-inflammatory mechanism for acne vulgaris also. I thank very much to everyone for listening to me.